Okay, good evening, all the aspirants present here. Today's topic is metabolic disease. It's a class 2, and the speaker that we have here is Dr. Vinod Jaiswal, sir. He is a consultant critical care at Medcare Royal Specialty Hospital in Dubai. Thank you, sir. So, you may take over.
Yeah. Good evening, everyone. Thank you for joining. Thank you for your time. Hope you are doing studying well. I don't know most of you where and what stage of MRCP you guys are. Part one, part two. Anyway, but I wish you all the best, and we'll begin our second session of metabolic diseases. The pattern is slightly changed from the last one which I took. Not much, but just marginally different. So we'll have questions and then explanation, then maybe some detail in the end, something. So we'll proceed. As of now, Dr. Nishi and Dr. Pratap, you are only there, right? Can you hear me?
Yes, sir.
Yes, sir.
Yeah. If you don't mind, if you can answer the question, that will be good. I think we are two only, so you can answer, no issues. If okay.
Yes, sir.
1 second.
Okay.
Yeah. So the topic this time I chose bone and mineral metabolism and hyperparathyroid. We'll try to cover questions and some relevant text on that. All right. 1 second. My screen is gone. Can you see or no?
So, the screen is visible.
Visible, huh? Okay. Okay, let's. 65-year-old woman has fatigue, mild confusion, and constipation. The lab results show calcium of 3, which is elevated, phosphate low, parathyroid elevated. Very simple and straightforward question. So, what would the likely diagnosis? You guys can answer, I think. Dr. Pratap and Dr. Nisha, right? You
Primary
guys,
hyperparathyroidism.
let's see. Yeah, so it's very straightforward question. Um, elderly women generally primary hyperthyroidism in elderly patients with parathyroid adenoma, hyperplasia, very common. Of course, classical is hypercalcemia, low phosphate, and PTH, increased parathyroid. And everybody knows this common mnemonic. Okay. We'll go to second question. A 58-year-old woman has persistent hypercalcemia. PTH is within normal limits. Phosphate is low, and vitamin D is mildly elevated. She's asymptomatic. What is the most likely diagnosis?
PTH secreting tumor. Sorry, the PTH is normal. Sorry, sir.
Yeah, PTH is normal. Yeah. It's
Sir,
a slightly tricky question.
it could be primary also because primary can have normal PTH also.
Exactly. So it's a primary hyperparathyroidism. So PTH can be normal, although it should be suppressed, but sometimes it is possible. And many times, even primary hyperparathyroidism and hypercalcemia present as asymptomatic or incidental finding. So it could be normal. Yes. Again, low phosphate and mildly high vitamin D support the diagnosis. The most important condition to distinguish between primary hyperparathyroidism and is the familial hypocalcemia. Okay. So in this, the main so PTH may be mildly elevated, but calcium excretion is very low. Okay. So the calcium to creatinine ratio is less than 0.01. This is the main diagnostic criteria for familial hypocalcemia. All right. Can we look at the other ones? Yeah. So if we look at the vitamin D intoxication, PTHs again will be suppressed and phosphate will be usually high. Tertiary hyperparathyroidism happens in long-standing CKD. Of course, PTH will be high in these cases with low calcium and high phosphate. Any doubt in between, you guys, you can ask. Okay. After the some questions, we'll go briefly over the pathophysiology of these conditions. Third question: 55-year-old woman with osteoporosis has calcium 2.4, which is normal, PTH 12.4, which is elevated, phosphate low normal. What is the most likely diagnosis?
Secondary.
Secondary hyperparathyroidism. Calcium is normal, PTH is high. Why it could be normocalcemic hyperparathyroidism? I think that was the answer. Yeah, normocalcemic hyperparathyroidism. Let's go back to the question first. Why it cannot be? You said which? Tertiary, right? Or secondary?
Secondary.
Yeah, secondary hyperparathyroidism happens due to different reasons of vitamin D deficiency or low calcium. In those conditions, it happens. Although here calcium is normal, PTH is elevated, and phosphate is also low normal. So it could be normocalcemic hyperparathyroidism, right? Any doubt?
Sir, in secondary, calcium should be low. If it is normal,
Yeah,
then it
that's the reason, no? Correct. Primary hyperparathyroidism,
both
sorry,
will
to
be.
calcium will be high, correct? In
Yes.
secondary hyperparathyroidism, PTH will go up to increase the calcium, right?
Yes.
To hypocalcemia is the stimulus. So patient will be hypocalcemic, should be, and PTH will be elevated. And phosphate again, this action of PTH, the phosphate will be low. So normocalcemic hyperparathyroidism is a variant of primary hyperparathyroidism often detected during osteoporosis workup. PTH is elevated, calcium is within normal limits, often due to early disease or intermittent calcium levels. Rule out secondary causes like vitamin D deficiency, CKD before diagnosing. Even CKD, we will call it as a tertiary hyperparathyroidism, right? Yeah. Next question. A patient presents with lethargy and confusion. He has calcium 3.6, which is of course elevated, PTH low, phosphate high, vitamin D high. What is the most likely diagnosis?
Vitamin D toxicity.
Vitamin D toxicity. Why? Why do you think vitamin D is high? Very unlikely to get vitamin D toxicity. First of all, calcium is very high. I don't think vitamin D will cause. Again, if vitamin D is high, then PTH will also go. Yes, it's a stimulus to decrease the PTH. But what's happening here? Hypercalcemia is there, PTH is low, phosphate is high, vitamin D is also high. So more goes in favor of, I think it is primary hypertension is ruled out, meal alkali is ruled out, ectopic PTH is ruled out. So we left with vitamin D toxicity or sarcoidosis. Correct. So very high calcium, I think it will go in favor of sarcoidosis. Yeah. In granulomatous disease like sarcoidosis and TB, macrophages convert vitamin D into active vitamin D independently of PTH. Correct? High calcium plus suppressed PTH plus high active vitamin D is equal to extrarenal synthesis of calcium. Phosphate is often too high due to increased gut absorption, and vitamin D toxicity also shows high vitamin D, but usually from over supplementation, which is very unlikely. So that could be an answer, but still it's an unlikely choice in this scenario. Of course, there will be more, maybe in exam, there will be more clinical features pointing sarcoidosis or vitamin D toxicity. A 30-year-old asymptomatic woman is found to have calcium 2.7, mildly elevated, PTH is elevated, urinary calcium creatinine ratio clearance ratio is 0.07. I think we already discussed this, correct? So it is familial hypocalciuric hypercalcemia. It's a benign condition generally, with lifelong mild hypercalcemia and inappropriately normal or high PTH. The PTH should be suppressed, but because the calcium excretion is high, so in urine, so there is a hypercalcemia. Uh, Primary, that's why I said no, that the distinguishing criteria is urinary excretion, so that it will distinguish from primary hyperparathyroidism. Okay, and it's also important to diagnose this condition because generally patients are asymptomatic and they do not need any treatment, right? If you don't have a low urinary excretion in the lab, so you cannot give the diagnosis of familial hypocalciuric hypercalcemia. In general, in the workup of hyperthyroidism or hypercalcemia, it is important to do urinary calcium excretion. A 63-year-old man undergoes parathyroidectomy for primary hyperparathyroidism. Post-op, he develops tetany, low calcium, low phosphate, high alkaline phosphatate. What is the most likely explanation?
So D.
D. Hungry bone syndrome. Yes. So generally, after the resection, because of a high circulating PTH before, or so all the calcium and phosphate go intracellular, and there is some explanation I'll also give. So after sudden drop in PTH, bone avidly takes up all the calcium and phosphate, so that causes profound hypocalcemia and hypophosphatemia. Generally seen in the patients who pre-op have actively high bone disease or high bone turnover. And of course, ALP remains elevated due to rapid remineralization. Why it cannot be other causes? Incomplete resection. It doesn't go in favor, correct? PTH, if the PTH is still there, an inadequate resection, so PTH should be high and calcium should be probably maintained. Vitamin D deficiency again will cause high secondary hyperparathyroidism. We may not manifest like this presentation with the context of a surgery. Hypoparathyroidism, of course not. It will take some time to establish. Hypomagnesemia, there's no relevant in this. So hungry bone syndrome is the correct answer. A 45-year-old man with chronic alcoholism complains of bone pain and muscle weakness. Investigation shows calcium low to normal, phosphate low, alkaline phosphate high, and vitamin D low. What is the likely diagnosis? Forty-five-year-old with chronic alcohol, with bone pain, with muscle weakness,
So B.
calcium. B, A or B, osteomalacia, right? Yes, it is osteomalacia. Generally defective mineralization of osteoid due to vitamin D deficiency, low phosphate, low normal calcium, elevated ALP, and low vitamin D. What will happen to PTH here? If it's not given, suppose PTH is given, so what will happen to PTH in osteomalacia?
Be high.
Yeah, it should be high. Yeah. Um, Correct. It could be also Because here vitamin D is low, so we cannot call it secondary hyperparathyroidism. Multiple myeloma will cause high calcium generally. Paget's disease generally normal calcium. Osteoporosis with the given history doesn't correlate with alcoholism and bone pain, so that's why osteomalacia. A 36-old vegan presents with fatigue and bone pain. Serum calcium 2, which is low, phosphate, which is low, alkaline phosphate is elevated, PTH is elevated. What is the likely diagnosis? I didn't give the options, right? Oh,
Page.
options. Sorry, the options I think I forgot to write the options. Anyway, so here the diagnosis is again the same, osteomalacia. As we discussed in the previously, all the findings are similar to the last patient. Here it was alcoholism leading to vitamin D deficiency. Here it is vegan patient, which is likely the cause. Again, the findings are same: phosphate low, calcium low, alkaline phosphate is high, and pH is elevated. This is the classical biochemical pattern in osteomalacia: decreased calcium, decreased phosphate, increased PTH, and increased ALP. Often seen in strict vegans or limited sun exposure. Now I think everybody, even I have a vitamin D deficiency, but if I check my all the tests, maybe I will have also some PTH elevated. I don't know. So in UE also generally there's mild vitamin. Everybody has vitamin D deficiency, but without any symptom. Pseudo hypoparathyroidism would have high phosphate and features of PTH resistance. Anyway, we'll come to that later. A 72-year-old man has increasing hat size and mild hearing loss. ALP is elevated, calcium phosphate normal. What is the most likely diagnosis? Osteomalacia, Paget's disease, hyperparathyroidism, multiple myeloma, osteoporosis. Any idea? It's an easy question, I think.
Paget's.
Yes, so it is a very classical question. I think you don't have to think much. Increasing hat size, mild hearing loss, and now compression is going on. ALP is elevated, all other labs are normal. So it perfectly fits into Paget's disease. Um, Here, what happens is the accelerated, or we say modified rate of bone remodeling, and it starts overgrowth of bone at multiple sites, most commonly skull, spine, pelvis, long bones, and that may cause nerve compression and any other compression symptoms common in elderly generally. Bone faint deformities will have, ALP is elevated, hearing loss. X-ray will have a lytic or sclerotic lesion, some cortical thickening, and again the treatment primarily is biphosphonates. If not responding, then calcitonin, and of late denosumab monoclonal antibodies can be used, but generally responds very well to biphosphonates and calcitonin. A patient presents with perioral numbness and carpopedal spasm. Lab shows calcium 1.7, PTH high. What is the most likely diagnosis or cause? So he definitely has hypocalcemia. PTH is high. We don't have the lot of total information.
CKD.
We don't have CKD history here. That will be tertiary hyperthyroidism. Mm, I think if not wrong, when I wrote the questions, answer was pseudo-hypothyroidism, no, vitamin D deficiency. Why vitamin D deficiency? As PTH will be high and 1.7 calcium is low, perioral numbness. So hyperparathyroidism is ruled out. Vitamin D deficiency could be. Pseudo-hyperparathyroidism, no. PTH will be high, but calcium will be, I think, normal. CKD, PTH will be high. Could be possible. It is possible. Diuretic is no. So, but when I wrote the questions, I targeted vitamin D deficiency. So you can give both the answers actually in this case.
It looks like secondary
Yes. Yeah,
hyperparathyroidism.
secondary hyperparathyroidism.
Both.
So it could be vitamin D deficiency. It is vitamin D deficiency. And you said correct? Yeah. Yeah. So low calcium triggers PTH, causes secondary hyperparathyroidism. Calcium absorption is impaired, leading to hypocalcemia, and of course differentiates from hyperparathyroidism because it will have a low PTH. A 25-year-old woman has hypocalcemia, short fourth metacarpal, and round face. Calcium low, PTH high, phosphate high. What is the diagnosis?
Pseudo hypoparathyroidism.
Yeah, it's very classical and common. Um, if you look at the other options, hypoparathyroidism, of course, ruled out. Vitamin D deficiency, calcium will be low, PTH will be high, phosphate should be low in general. Renal failure, uh, but renal failure patient will not have 25-year-old with hypocalcemia, short fourth metacarpal, and round face. So that's ruled out. Magnesium, of course, no. So it's a pseudo hypoparathyroidism. What happens here is the group of different disorders actually, and defined by unresponsiveness to PTH in the kidney and the bone. So PTH receptors, PTH is there, but the receptors are not responding or are resistant to the PTH at receptor level. So that's why the PTH goes high, but calcium remains low, and that's why it is called as pseudo hypoparathyroidism. And phosphate is high despite the PTH is high. The calcium remains low because of the end organ effect is not happening, and again that's why the phosphate is also high. Physical signs, generally it's called Albright's hereditary osteodystrophy, short stature, short fourth or fifth metacarpal, and obesity. A 42-year-old man has the following labs: calcium 2.1, phosphate 1.8, PTH is low. What is the most likely diagnosis? Calcium low, phosphate high, PTH low. Hmm? It's hypoparathyroidism, right? It's simple, no? Until now, we're dealing with hyper. Now it is classical hypoparathyroidism. Calcium is less, phosphate is high, PTH is less. So it fits into all. Pseudo hypo is ruled out. Vitamin D deficiency, PTH will be high. Tumor lysis doesn't fit. CKD, PTH will be high. So it's a primary hypoparathyroidism. So decreased calcium, increased phosphate, decreased PTH, primary hypoparathyroidism. Common causes post-thyroidectomy, autoimmune. Shows high PTH, low, again same. Vitamin D deficiency usually has low phosphate due to compensatory PTH rise. Correct? A 68-year-old woman with recent vertebral fracture has a T score of minus 2.8 on DEXA scan. What is the diagnosis? Normal bone density, osteopenia, osteoporosis, osteomalacia, Paget's disease. If you know the T score, sorry?
Osteoporosis.
Yes. So it is osteoporosis. The WHO definition is T score less than 2.5 is osteoporosis, and 1 to 2.4 is osteopenia. Vertebral fractures, then hip, rib fractures are common. different reasons, age, menopause, steroids, smoking, inactivity, multiple things can lead to osteoporosis, particularly postmenopausal women. A child has bowed legs, low phosphate, normal calcium, low vitamin D. What is the likely diagnosis?
It's only my
Uh,
job.
Hello. So a child with bowed legs, deformed legs, low phosphate, normal calcium, and low vitamin D.
Sir, nutritional rickets.
Nutritional rickets, low calcium, low vitamin D. But as a child, vitamin D dependent rickets is less, X-linked hypophosphatemic rickets. Yeah, all other things, I think the phosphate will not be low, correct? Because that will be secondary hypopathoidism, right? Leading to. So I think it will go in favor of X-linked hypophosphatemic rickets. Let's see the answer. Yeah. Why? The defect in phosphate absorption in proximal tubules. It's a FX mutation. Low phosphate, normal calcium, and low active vitamin D. Rickets signs despite adequate vitamin D and calcium intake. So let's go back to the options. Why it cannot be nutritional rickets? I think phosphate will be high a little bit, in my opinion. If you go to the physiology of PTH and calcium. So nutritional rickets, vitamin D rickets, this will be, I think, ruled out. Fanconi syndrome, and these are, of course, not fit, doesn't fit. Agree?
Yes, sir. Yes.
We'll go briefly over, we have done many questions. We'll go briefly over the normal pathophysiology of PTH secretion and calcium, how it gets regulated. So I think you all must be knowing it. So very common, and without this knowing, I think it's difficult to diagnose the conditions. So it's very important to know how the PTH regulates calcium metabolism. So low calcium will cause rise in PTH, and rise in PTH will have actions on bone and in the gut. So in the bone, it will increase the turnover, it will increase the efflux, it will increase calcium reabsorption from the gut. At the same time, it will increase phosphate excretion in the urine. In the kidney, it will convert 25 hydroxy vitamin D to 125 hydroxy vitamin D. Again, it will help in absorption of uh, calcium and phosphate. All these effects will restore the calcium, and of course, it will keep the phosphate also normal. It's not that if the homeostasis is working properly and hypocalcium is happening and PTH is getting secreted, the phosphate has to be low. It is not. It will try to bring it back, and in the disease state only, when it is not corrected, yes, the phosphate will be low. Okay, but in general, in the body, phosphate should be normal. Any confusion here? This is very basic and simple, right?
Yes, sir.
Okay. So, what are the key concepts here? Low calcium triggers parathyroid hormone. The parathyroid hormone increases calcium by bone resorption and renal reabsorption. So, and decreases phosphate by promoting renal excretion. At the same time, it convert 25 vitamin D to 125 hydroxyvitamin D through stimulation of 1 alpha hydroxylase. And by this turn, 125 dihydroxyvitamin D will increase gut absorption of calcium and phosphate, and supports bone mineralization. What are the negative feedback is elevated calcium and vitamin D, which will suppress the PTH. So, how we will diagnose primary hyperthyroidism in adults? Okay, we have seen the basic metabolism, how calcium secretion, PTH regulates calcium metabolism, and but we have to diagnose because different conditions, phosphate, vitamin D, calcium, all very interrelated, and different conditions might be confusing. So, how do you diagnose primary hyperparathyroidism in adults? So, hypercalcemia, first you have to confirm by repeat measurement, and then you check parathyroid hormone and calcium. It should be total calcium corrected with albumin or ionized calcium. Either of the two should be enough. Most of the centers only normal calcium is available, so you have to correct with albumin. Is the then PTH is frankly elevated with persistent hypercalcemia? Yes. So PTH is elevated and calcium is high. So it is very straightforward. Primary hyperparathyroidism. Okay. But PTH may be upper normal or minimally elevated. Still, primary hyperthyroidism is possible, as we discussed earlier. But we have to consider familial calciuric hypocalcemia. We have to measure urine calcium and creatinine ratio should be less than 0.01. Okay. And if PTH is not elevated, then PTH is low, then primary hyperthyroidism is highly unlikely. Then we have to rule out the causes for non-PTH mediated causes of hypercalcemia, correct? Which could be vitamin D intoxication, extra supplementation, or this what we call it, any malignancies which cause secretion of calcium.
Sarcoidosis.
Yeah, sarcoidosis particularly, and lung cancer also. So
Multiple
this,
myeloma.
yeah, multiple myeloma. mm, yeah, calcium will be high in the late stages. Yes. So all these things you have to rule out when PTH is low. Correct. Any confusion on anything? I think you guys have read very well. The questions I kept is very simple and straightforward. But maybe in the exam in MRCP part 2 particularly, they give you more details, lengthy questions. But that makes easy to make the diagnosis. So you really have to few conditions like Paget's disease, FHH, primary hyperthyroidism, secondary, tertiary hyperparathyroidism, then pseudo hypothyroidism. This just few important subtle diagnostic findings and clinical signs you need to know. So, and if you know the basic what happens to calcium metabolism, you should be able to answer the question. Okay. So it's, I don't think it is difficult, but you tend to forget and you tend to get confused with the different conditions. And if you know the calcium metabolism, it should be easy to answer the questions. Any doubt, guys? We'll move to some more questions on some other minerals, and then we'll close it. It's not a long session today. It's a small session only. Okay. A 70-year-old woman with CKD is given magnesium hydroxide for constipation. She becomes hypotensive and drowsy. Which electrolyte abnormality is most likely?
Hypercal-
Hypocalcemia. Sorry.
Hyperkalemia. Hyperkalemia.
Hyperkalemia will not cause hypotensive and drowsy. So hypocalcemia is unlikely. Patient will have different features of hypocalcemia. Hyperkalemia for constipation, no, patient will not have hypotension and drowsiness. Hypermagnesemia, patient has received magnesium, patient is CKD, is possibility. Hyponatremia, no, it will not cause. Hyperphosphatemia, no. So it fits into hypermagnesemia, correct? Seen in CKD with magnesium containing antacids, hypertension, bradycardia, decreased reflexes, weakness, confusion, in severe cases, paralysis, and cardiac arrest. May not be a common question in the MRCP, but still I thought it's important because we are finishing the bone and minerals topic today. So I thought to include magnesium. So if you look, like if you guys, I don't know, in clinical practice also, if you have noticed, magnesium is, you give in asthma, you give in PIH or eclampsia. So there it relaxes the muscle action. It has a blood antihypertensive properties, right? So here it is, and in the context of CKD, so the hypermagnesemia fits best. All other electrolyte abnormality may not cause hypertension and drowsy. And of course, many times this electoral abnormality happens in combination with others. So yes, possibly there might be some other electoral abnormality may be present, but here the reason in the question also it is given, so it is hypermagnesemia. A 58-year-old alcoholic presents with muscle cramps and positive stochastic sign. Lab show calcium is low, phosphate is normal, PTH is low, magnesium is low. What is the most likely cause of low calcium? So here low calcium, low PTH, low magnesium, and normal phosphate. What is the cause of low calcium? Is it hypoparathyroidism? Phosphate is normal, calcium is low, pH is low. It's possible, but magnesium will not be. Vitamin D deficiency, no. CKD, no. Hypomagnesemia, it is magnesium is less, it is possible. Pseudo hypoparathyroidism, pH will be high. So there can be two reasons here: hypoparathyroidism or hypomagnesemia. But if you look at the history, patient is alcoholic with muscle cramps and positive cholesterol because of these hypocalcemic signs. Looks like here the cause goes more in favor of hypomagnesemia, right? Because we don't have any reason to have a hypoparathyroidism to this patient without any surgery or causes of hypoparathyroidism, right? Let's look at this. Yes, hypomagnesemia. Magnesium is essential for PTH secretion. Severe hypomagnesemia can inhibit PTH release, leading to functional hypoparathyroidism and hypocalcemia. Correct. There were two negative feedback mechanism for PTH. One was vitamin D, correct, and high calcium, correct. So, but another factor is also can cause less secretion of PTH is magnesium. It can inhibit PTH release and can cause functional hypoparathyroidism. Unlike true hypoparathyroidism, it is reversible with magnesium correction. Common causes alcoholism, diarrhea, diuretics, and aminoglycosides. Right. Very commonly, you will find hypomagnesemia in clinical setup. All right, understood, guys? A 76-old man with CKD presents with drowsiness hypotension, he had been using over the counter magnesium hydroxide for constipation. So, what is the likely lab result? All related to magnesium 0.5, 0.8, 1, 2.2, 0.7. Again, similar presentation CKD with drowsiness, with hypertension, using over the counter magnesium for constipation, presented with drowsiness and hypertension. So, what do you expect the magnesium level to be? Low or high? If you know this, then you can answer the question. Is it low or high? Hmm? Should be high, no? We just discussed, correct?
Yes, sir, talks.
Yeah, should be more than 2.2. So hypermagnesemia is rare unless renal function is impaired. You know, symptoms are dose dependent. Around 2 millimole, it will cause nausea, vomiting. More than 3, hyporeflexia and weakness. That is what you monitor in eclampsia for the knee jerk, and you monitor the magnesium levels. Generally, they try to keep below 4 millimole, and more than 5 millimole heart block, respiratory depression. Treatment is, of course, IV calcium gluconate fluids, and if life threatening and no time to correct, then dialysis if severe. Right. This was all today, guys. It was a small session because I don't wanted to mix any other session with this. PTH and calcium metabolism is very important, and you'll definitely get a lot of questions on. I didn't took a lot of questions on Paget's. Paget's also has. That's why I included in couple of slides what are the symptom, signs, and treatment. You should be able to answer. Familial hypocalcemia, pseudo hypoparathyroidism, primary hyperthyroidism, you know. So these are very common and will definitely get questions. Although I kept strictly avoided the other diseases like sarcoidosis that can be covered in other, but of course, sarcoidosis, multiple myeloma, all these, and mm, malignancies causing hypercalcemia, those questions also can come. But I think you should be able to answer after this session. What do you think, guys, for today's session?
Yes, sir, it was nice.
You guys know, I think most of the things you are knowing. I think it was just a revision for you guys, I hope. Yeah. All right.
Thank you, sir. Thank you, all the aspirants. If any question arises, we'll be having the next session soon. Thank you.
Yeah, and Fatima,
Yes, sir.
if they want particular topic to be in detail to be covered, or
Yes.
something you can tell me beforehand, then as
Okay.
of now, I'm just preparing according the topics you guys have given me, you
Okay.
know. So if
Okay,
something,
sir.
if they face any difficulty in particular topic or area, then I can provide the material, or I can make a
Sure,
PPT
sure.
and
All the
accordingly.
aspirants, if any other topics you want to revise or anything, please give me a text. I will be organizing the classes accordingly. Thank you.
Thank you. Thank you, guys.